Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Welcome back to the deep dive. Today, we are staring down a scenario that I think effectively defines the term surgical emergency.
Oh, absolutely.
You know, it's 2 a.m., the coffee's cold, the ER docs are looking a little nervous, and they use that dreaded phrase, acute abdomen.
It's a race against time, a collision of biology and mechanics.
Exactly. We are talking about gastric perforation.
It is the absolute nightmare scenario. It's the case every general surgeon dreads, but absolutely must recognize instantly. We're talking about a full-thickness hole in the stomach. It's dramatic, it's dangerous, and honestly, the management has evolved.
It's not just see hole, sew hole anymore.
Not at all.
And that's exactly why we're doing this. We want to get into the weeds of that management, but before we metaphorically unzip the patient, who is this deep dive really for?
This one is specifically tailored for surgeons, surgical trainees, and I think emergency medicine doctors who need a high-yield refresher on the latest evidence-based management.
Right.
We are assuming, the basics of anatomy, so we're going to focus strictly on the decision-making matrix, the why behind the what.
Okay. And because we are dealing with some pretty high-stakes medicine here, we need to get the mandatory housekeeping out of the way.
Yes, this is crucial. The content we're discussing today is for informational and reference purposes only. Clinical guidelines vary, sometimes significantly, by region and hospital.
So follow your local protocols.
Absolutely. Listeners should strictly follow their local protocols and institutional guidelines in their actual clinical practice. We are summarizing sources to build a knowledge base, not giving medical advice for a specific patient.
Perfectly said. So our mission today isn't just to talk about patching a hole, it's about the entire timeline.
From the moment that patient hits the ER door, through resuscitation and onto the operating table.
And even what happens after the table.
This is where a lot of the mortality actually creeps in, yeah.
We've got a stack of sources guidelines, studies on Bowie and PLP scores, surgical technique reviews. So let's start at the physiological level. What are we actually dealing with?
Well, structurally, it's a full-thickness disruption of the gastric wall. And that matters because the stomach is a reservoir. When it breaks, you get spillage.
Which is basically a chemical spill inside the body?
It is. Initially, you're dealing with chemical peritonitis. It's acid and bile just burning the peritoneum. Intense, searing pain. But, and this is the clock ticking, within hours, bacteria translocate.
So that chemical burn shifts to bacterial peritonitis?
And then sepsis. And if you don't intervene, multi-organ failure.
So what's causing the blowout? I feel like peptic ulcer disease, PD, is still king here.
It absolutely is.
Yeah.
PED is the usual suspect. H. pylori infection, chronic NSAID use, smoking, steroids. That combination just weakens the mucosa until pop.
The demographic has shifted though, right?
It has. It used to be young men with duodenal ulcers. Now it's increasingly elderly women with gastric ulcers, often on NSAIDs for arthritis.
That's a really important shift. But PUD isn't the only culprit.
No. You have to keep a high index of suspicion for malignancy gastric cancer that ulcerates through. Then there are stress ulcers in the ICU, trauma, and, increasingly iatrogenic causes.
From endoscopy.
Exactly. As we get more aggressive with endoscopic procedures, we see more perforations. The management for those is a little different, which we'll get to.
Okay, let's walk through the timeline. The clock starts now. The patient presents. We all learn the classic textbook presentation.
Sudden onset. Severe, knife-like epigastric pain that quickly generalizes. And the physical exam finding everyone remembers.
Board-like rigidity.
Board-like rigidity. You touch the abdomen and it feels like a piece of wood.
That's the classic.
That is the classic. But here's the trap, and this is where you can get burned in the ER. That presentation relies on a robust immune response.
Let me guess, the elderly don't read the textbook.
Not at all. An elderly patient or someone who's immunocompromised or on high-dose steroids, they might not mount that dramatic response. They present insidiously.
Vague pain.
Vague pain, maybe some confusion, or just unexplained sepsis. They often don't have that board-like abdomen.
So if you're waiting for that rigidity,
you might be waiting until the autopsy. You have to treat unexplained physiological decline as a potential abdominal catastrophe until proven otherwise.
That is terrifying. Okay, so you suspect it. You need to see it. Old school teaching says get an upright chest x-ray.
And look, an erect CXR is okay. It's quick. It shows free air in about 70% of cases, but okay isn't best.
You're missing 30%.
You're missing a third of them. The sources are pretty adamant that the CT abdomen pelvis is the standard now.
The diagnostic modality of choice.
Absolutely. With IV contrast, it gives you so much more. A CXR just tells you there's air.
Yeah.
A CT tells you where the hole might be, how much contamination there is, and crucially, it can spot a sealed perforation.
Which changes the management plan completely.
It changes everything. And if it's not a perf, the CT tells you what else it might be. Pancreatitis, cholecystitis. It clears the fog.
Quick note on endoscopy. If you suspect a perforation, are you putting a scope down?
Generally, no. In frank peritonitis, you're just blowing more contamination into the belly. You avoid it unless you're, say, treating an iatrogenic injury you just caused, or maybe in a very stable patient to check for cancer. But for the acute abdomen, keep the scope away.
Got it. Okay, diagnosis made. You see the free air on CT. We aren't rushing to the elevator just yet, though?
No, this is the damage control phase. It starts before the OR. You have to stabilize the physiology first. You can't operate on a corpse.
So back to our ABCDEs.
Standard sepsis protocols. Large bore IVs. Aggressive crystalloid resuscitation. The guidelines suggest targeting a MAP of greater than or equal to 65 and urine output of at least 0.5 ml/K bilite.
Fill the tank.
You have to, because they're profoundly dehydrated from third spacing. And then broad-spectrum antibiotics, obviously.
Covering gram-negatives and anaerobes.
Yep. But here's a nuance from the sources that stands out. Antifungals.
Yeah, I feel like there's a tendency to just throw everything at these patients.
And the evidence says don't do that routinely. Candida peritonitis is bad, yes, but routine fluconazole for every perforated ulcer isn't supported. It's reserved for high-risk groups.
Immunocompromised, long ICU stays.
Exactly. So while the fluids are running, we need to figure out how likely is this patient to die. We have scoring systems for this.
The crystal ball. The most famous one is the Bowie score.
I love the Bowie score because you can do it on your fingers. It's simple.
3 points. 1, shock on admission. 2, major medical comorbidity. 3, perforation for more than 24 hours.
And the score correlates steeply with mortality. 0 points, you're fine. All 3, mortality can approach 40 or 50%.
There's also the PLP score mentioned in the literature.
The PLP score is more complex. It adds age, labs like creatinine. The study suggests it's actually more accurate than Bowie, but it requires a calculator. So it's less used at the bedside when things are moving fast.
But regardless of the score, the death factors are consistent.
Yes. Elderly, elevated creatinine, shock. And this is the big one, delay. A delay of more than 24 hours before treatment is the biggest modifiable risk factor.
So speed kills, or rather, the lack of it does. Okay, let's get into the decision-making. We have a hole in the stomach. Common sense says sew it up, but there's this concept called non-operative management.
The Taylor method. It sounds counterintuitive, doesn't it? Leaving a hole alone.
Very. So what are the criteria? I assume we aren't doing this for the guy with the board-like abdomen.
Yeah, absolutely not. This is for the exceptional case. The patient has to be hemodynamically stable, no diffuse peritonitis, and the CT scan is the gatekeeper.
It has to show a sealed perforation.
Exactly. The body has already started to wall it off, usually with the mentum or the liver. If the body's doing the work, we just support it.
With what?
The protocol is strict: NPO, NG tube for decompression, IV fluids, and high-dose PPIs. And antibiotics, of course.
And you're watching them like a hawk.
Constant monitoring in a high-dependency setting. Any deterioration, any rise in pulse, any increase in pain, you abandon ship and go straight to surgery.
It's a high-wire act.
It is, but for a frail patient with a tiny sealed leak, it can save them from a laparotomy.
Okay, but for most patients, surgery is the main event. Let's talk strategy. Goal is source control.
Ideally within 6 to 12 hours.
And the big debate, laparoscopic versus open. Is that still a debate?
Less of one now. It's more about resource and patient selection. If the patient is stable and you have the laparoscopic expertise, lap is preferred. Less pain, shorter stay.
But there are hard stops for lap.
Definitely. If the patient is in shock, has severe sepsis or gross contamination, food and bile everywhere, or if the surgeon just isn't comfortable, you open. You make a midline incision. And there's a principle mentioned in the guidelines that I think is the golden rule here.
What's that?
The simplest effective technique. That is the mantra. This is emergency surgery. You are not trying to create anatomical perfection. You are trying to save a life.
Don't let perfect be the enemy of alive.
Exactly. Don't attempt a complex reconstruction if a simple patch will do.
Let's talk about that simple patch. The workhorse for benign ulcers less than 2 centimeters.
The Graham patch. Elegant in its simplicity.
How's it done?
You identify the hole, You place, say, 3 full-thickness sutures across the perforation. But, this is key, you don't tie them yet.
You leave them long.
You leave them long. Then you grab a pedicled ton of healthy omentum, lay it over the hole, and then you tie the sutures over the omentum.
So you're not sewing the hole shut so much as plugging it with living tissue.
Like putting a cork in it, but the cork brings its own blood supply. If you just sew the hole shut, the inflamed tissue is friable and the stitches will just cut through. The omentum provides the scaffolding.
And a pro tip for finding that hole laparoscopically.
The tire leak test. Inject air or methylene blue through the NG tube while the abdomen is filled with saline. You look for bubbles or blue fluid. It points you right to the pathology.
Brilliant. Now, what if it's a giant ulcer, greater than 2 centimeters, or the tissue's just falling apart?
This is where the simplest effective technique rule gets tested. A simple gram patch has a high failure rate here.
So what are the options?
You have to escalate. You might try an omental plug, literally stuffing omentum into the hole. You might do a wedge excision. But sometimes you have to do a distal gastrectomy.
A Billroth. In the middle of the night. That's a massive operation for a sick patient.
It is. And the expert warning here is stark. In an unstable patient, avoid extended resections. You might just patch it as best you can, put in a huge drain, and get out. Better to have a controlled fistula than a dead patient on the table.
That leads us into the malignant perforation. You go in and it's not a benign ulcer. It's hard, irregular. It's cancer.
This is a terrible dilemma. The oncology textbooks say an emergency oncologic gastrectomy, taking it all out with clean margins, gives better long-term survival.
But the physiology textbooks say that operation will kill them right now.
Exactly. The mortality is up to 50%. You're flipping a coin on their life right now to maybe give them better cancer outcomes later.
So what's the move?
A staged approach. If they're unstable, you treat the perforation. Close it, lavage, maybe take a biopsy, let them recover from sepsis. Then you bring them back weeks later for the formal cancer surgery when they're strong enough.
Balance physiology against oncology makes sense. What about iatrogenic perforation? The endoscopist poked a hole.
Increasingly, no surgery at all. If it's recognized right away, they can often fix it endoscopically. Clips, stents, surgery is now the backup plan.
Amazing how that has shifted. Now, the absolute worst case scenario, the moribund patient, the lethal triad, acidosis, coagulopathy, hypothermia.
This is damage control surgery. You do not reconstruct. You stop the leak, staple it, suture it, whatever's fastest, abbreviated washout. And you do not close the fascia.
The open abdomen.
You leave the abdomen open with a negative pressure dressing, a vac pack. If you close them under tension, they'll get abdominal compartment syndrome and die.
It sounds barbaric, but it's life-saving.
It is. But it has risks, like enteroatmospheric fistulas, a total nightmare. But again, the alternative is death on the table.
Survival first, reconstruction later. So we've survived the surgery. We aren't out of the woods.
No. Immediate care is about sepsis management. Adjust antibiotics based on cultures. Early nutrition is key. High-dose PPIs are non-negotiable.
And the complication we are sweating over.
The leak. If the patient gets tachycardic on day 3 or 4, or you see bile in the drain, you have to worry the patch failed.
Test of choice.
CT scan with water-soluble contrast.
And looking at the long game, the job isn't done at discharge.
This is where we often drop the ball as surgeons. If it was PU, you must test for and eradicate H. pylori. You have to have the hard conversation about smoking and NSAIDs.
And checking for cancer.
Absolutely. If you just patch the hole, that patient needs a surveillance endoscopy in 6 to 8 weeks. You have to make sure you didn't just patch a cancer that's going to grow back.
So let's bring this all together.
Yeah.
What does this mean for the surgeon standing in the ER at 2 a.m.?
Gastric perforation is about speed and judgment. Diagnosis is the CT scan. Resuscitation is aggressive. And the surgery. It should be the simplest effective technique. Don't let perfect be the enemy of alive.
And that leads to our provocative thought for the day.
I think it's this balance between oncologic perfection and physiological survival. We're trained to be thorough, to get clean margins, but sometimes the best surgeon is the one who knows when not to do the big operation.
The one who has the discipline to just patch and drain.
And live to fight another day. It requires suppressing your ego for the sake of the patient's physiology.
That is a powerful takeaway, recognizing that good enough in a crisis is actually perfect.
Precisely.
Well, that brings us to the end of this deep dive on gastric perforation. We hope this refresher helps you the next time that red phone rings.
And if you found this useful, or it sparked a thought, please share it with at least one colleague or friend in the medical field. Let's spread this knowledge.
And don't forget to check out our YouTube channel and social media pages. We'll have some visual aids up there for you. The Graham patch, the Bowie score algorithm.
Visualizing it always helps.
To all the surgeons and doctors listening, thank you for the work you do saving lives in the middle of the night.
Stay sharp.
We'll see you on the next deep dive.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.